We can define a liver incidentaloma as an asymptomatic liver abnormality found serendipitously on an imaging examination that was performed for another reason. And that's the way it's normally defined. I would like to define another type of incidentaloma which pertains particularly to the cancer population, and that is a liver lesion that we identify in a patient with a newly diagnosed cancer. Now, the problem that we face is that the prevalence of benign lesions in the liver is very high, and it increases with age. This study showed that benign hepatic masses were found in more than half of consecutive adult autopsies, and on imaging, we see them very commonly, as you all know. In this CT study, benign hepatic lesions were seen in 1/3 of patients, incidentally, in patients undergoing portal venous phase helical CT. So we see these commonly, and we need to figure out what to do with them. Should we ignore them? Should we follow them? Is there anything further that we need to do with them? And the approach that I take to dealing with hepatic incidentalomas is three-pronged. First, we need to look at the imaging features and determine, are these benign imaging features? Are they clearly malignant imaging features? Or is it something indeterminate that we need to evaluate further? And then we need to figure out how to stratify this patient into a risk category, which is to say, how likely do we think it is that this individual would have a malignant liver lesion? And then based on those two strategies, then we can determine what our management strategy should be. So with regard to imaging features, I think there are three general types of lesions that we see incidentally in the liver. The lesion can look cystic, it can be hyper-enhancing, or it can be hypo-enhancing relative to background liver. Now, in addition, I think another important category has to do with size, and that is we very frequently encounter very small lesions that are too small for us to accurately characterize based on our imaging study. And so that's a different category that I think we need to deal with as well. Now, there are also some more specific imaging features that can give us some clues as to what we're dealing with. So we need to look at the size, shape, and location of the lesion. Is it homogeneous or heterogeneous? Echogenicity, attenuation, and signal intensity depending upon whether we've identified it on ultrasound, CT, or MRI. Are the margins well-defined or ill-defined? Enhancement pattern obviously is very important. And then there are some more specific features, some of which have been shown in the earlier presentations, including central scar, internal hemorrhage, internal lipid, and capsular retraction if the lesion is subcapsular. Now, with regard to risk stratification, I think an easy way of dealing with this is simply to categorize patients into two risk groups, a low-risk group and a high-risk group. The low-risk group is simply patients who don't have a known malignancy. But in addition, I think we should specify that these patients should have no symptoms attributable to the liver and should have no risk factors for hepatic malignancy. The high-risk group is simply the cancer population, patients who have a known extrahepatic malignancy. But I would specify also that we should exclude patients with cirrhosis. And one of the problems I have with the ACR guidelines on dealing with liver incidentalomas is that in their high-risk group, they lump patients with malignancy and other risk factors for malignancy with patients with cirrhosis. And I think that muddies the decision-making process because Cirrhotics are a whole different group. They have a very different set of imaging issues and characteristics and risks, and I think their management needs to be somewhat different. So for the purpose of this discussion, I think we'll exclude cirrhotic patients and deal just with cancer patients who do not have cirrhosis. Now, there are a couple of studies that were done a long time ago, this one 25 years ago, that I think give us some helpful information as to how much emphasis to place on these very small incidental lesions that are too small for us to characterize. This first study from Emory University looked at lesions that at that time they considered too small to characterize, 15 millimeters and smaller, and they followed these patients for at least 6 months and determined whether the lesions were benign or malignant based on follow-up, and they divided their patient groups into those with a known malignant neoplasm and those with no known malignant neoplasm. And what they found was that nobody in the no malignant neoplasm group had a malignant lesion. All of these incidental lesions were benign, whereas in patients with a known malignant neoplasm, 2/3 were benign and 1/3 were malignant. So I think the take-home message from this study is that when you identify a very small lesion incidentally in a patient with no known malignant neoplasm, the chance that it will be malignant and needs to be further evaluated or followed is extremely low. And even in patients who have a known malignancy, the majority of these lesions are benign. But of course, these patients do need to be followed because of their risk of malignant lesions. Now, this is another study that I think is very helpful. This was 7 years later from Memorial Sloan Kettering, which of course is a cancer hospital. So this entire group of patients are cancer patients. In this study, they considered lesions 1 centimeter and smaller, too small to characterize, and again followed these patients for at least 6 months. And what they found was that even in this cancer population, nearly 90% of the lesions turned out to be benign. So even in cancer patients, we need to be a little bit skeptical about these very small lesions, particularly when we're doing an initial staging study on a patient with a newly diagnosed cancer. We can't jump to the conclusion that every little lesion in the liver we see is a metastasis. Now, with regard to management strategy, we use the first two features, the imaging features, and how likely we think it is for the patient to have a malignancy to determine what our management strategy should be. So if our imaging characteristics that we identify are clearly benign, then obviously no further evaluation is needed. However, if the lesion is indeterminate, if we can't tell if we're dealing with a benign or a malignant lesion, then we have various options. And one option is imaging follow-up. Another option is to do initial imaging at the time the lesion is identified to try to better characterize the lesion. And the third option is to biopsy it. And which one of these options we choose depends upon our risk stratification, how likely we think it is that this patient has a malignant lesion. And secondly, I think another important consideration is patient and physician preference, and also how much of an impact it will have on the patient's immediate clinical management. So all of those things need to be taken into account to decide what the next step will be. Now, if the characteristics of the lesion on our initial imaging study are clearly malignant, then we might choose to do an additional imaging study to better characterize the lesion. Maybe we can make a specific diagnosis that will allow us to determine what the appropriate management should be. We could biopsy. Or in some cases, we might even decide just to go ahead and treat empirically because the imaging findings are characteristic enough or the clinical history is characteristic enough that it allows us to just go ahead and treat the patient. And again, that will depend upon risk stratification and upon how these different approaches will impact the patient's immediate clinical management. Now, with regard to additional imaging, we have various choices. So if we identified this incidentaloma on an ultrasound examination, then our options are contrast-enhanced MRI, contrast-enhanced CT, and contrast-enhanced ultrasound. And for MRI, I agree with Johnny that the best way to approach this is to use a hepatobiliary agent for an incidentally identified lesion from another imaging technique, because that will give us our best chance of making a specific diagnosis. If we saw the lesion initially on a non-contrast CT, then we have the same options to do a contrast-enhanced MR, CT, or ultrasound. And if we saw the lesion initially on a contrast-enhanced CT, then we could opt to go to MRI or contrast-enhanced ultrasound to try to make a specific diagnosis. Now, very rarely, we might want to use a very specific nuclear medicine technique like one of the ones I've listed here, but that's quite rare. I think in the vast majority of cases, the appropriate options for further imaging are going to be the ones listed here. Now, what about differential diagnosis? If the lesion we identify has a cystic appearance, the things to consider, and of course this is not a comprehensive list, but these are some of the more likely things, are a simple cyst, biliary hamartoma, biliary cystadenoma, myeloma, hydatid cyst, abscess, cystic neoplasm, and which ones of these we consider more highly depend upon patient characteristics, history, and laboratory values as well. For a hyper-enhancing incidental liver lesion, the things that we consider include hemangioma, focal nodular hyperplasia, transient hepatic attenuation or intensity difference, vascular shunt, hepatocellular adenoma, nodular regenerative hyperplasia, hepatocellular carcinoma, or hypervascular metastasis. And then, of course, there are all kinds of rare lesions like the ones that Johnny showed you that are much less common. Now, if we have a hypo-enhancing lesion, the things to think about include focal steatosis. Hemangioma can be hypo-enhancing on a standard portal venous phase CT. Angiomyolipoma, lipoma, metastasis. HCC can be hypo-enhancing on a portal venous phase study, or cholangiocarcinoma. Again, a non-comprehensive list, but some of the major things that we consider. Now with that, I'd like to go through some examples, and I'm going to concentrate on patients with newly diagnosed cancer. So here is a woman with a newly diagnosed pancreatic cancer, and we did our staging examination with CT, and we identified this hypoattenuating lesion in her liver. So we did an MR examination to further characterize this lesion, and as you can see, on these are in-phase and opposed phase MR images, and on the opposed phase image we see signal dropout, indicating that this is simply focal steatosis, even though it looked very concerning for a hepatic metastasis. Now, this was a woman who came to us with this study from an outside institution with newly diagnosed melanoma, and she had this hypoattenuating lesion in her liver. So again, we did MR with a hepatobiliary agent. And as you can see, this lesion has the typical characteristics of focal nodular hyperplasia, homogeneous enhancement during the arterial phase with a central scar. It equilibrates with liver on the portal venous phase, and then it shows enhancement during the hepatobiliary phase. So typical focal nodular hyperplasia. Now, this was a difficult lesion. This was a 58-year-old woman with newly diagnosed lung cancer, and this lesion was very concerning for metastasis. It shows some peripheral, some rim enhancement, a little bit of central enhancement. And so we did an MR to further characterize this lesion. And here we have arterial phase, portal venous phase, and T2 weighted imaging showing some arterial phase hyperenhancement, washout during the portal venous phase, and T2 hyperintensity. So still nonspecific. We still can't be sure whether we're dealing with a metastasis or something else. But then when we get to the T1 weighted images without and with fat suppression, you can see that with fat suppression, this lesion shows homogeneous signal drop, indicating that we're dealing with a lesion that has macroscopic fat within it. So we're dealing with either a lipoma or an angiomyolipoma. And given the arterial phase hyperenhancement, this is likely to be an angiomyolipoma. It was biopsied, and it was an angiomyolipoma. Now, this was a woman with newly diagnosed breast cancer, and she has numerous small, well-defined hypoattenuating lesions that look almost cystic, and this is a very typical appearance of biliary hamartomas. And so we probably could have just made that diagnosis based on the CT. Nevertheless, we did an MR for further evaluation, and again, we see the very typical appearance of biliary hamartomas. So these are not hepatic metastases. Patient with newly diagnosed pancreatic cancer, we see this on our initial study with MR. We see this peripheral hypointense lesion in the liver. And on the diffusion weighted imaging, we see that it is restricting diffusion. So we thought this was highly likely to be a metastasis based on this, and it was biopsied and was a metastasis. Here's a similar patient with newly diagnosed gallbladder cancer, and we identified this lesion in his liver on T2. There's probably a little bit of a T2 correlate right here. And then again on the diffusion weighted image, it was restricting diffusion. So we thought this was highly likely to be a metastasis, and it also was a metastasis. So to summarize, the prevalence of benign liver lesions in adults is very high, and it increases with age. And we see these incidental liver lesions on a daily basis. Lesions that are too small to characterize in patients who do not have cancer are almost always going to be benign lesions and don't need to be evaluated further. Even in cancer patients, they're more likely to be benign, but of course, we need to follow these patients because they are at risk for metastases, and so at the very least, we need to do imaging follow-up. If further imaging is needed, in my opinion, the technique of choice is MRI, preferably with a hepatobiliary agent. And the management strategy is based on the imaging features that we can identify on the study in which we identify the lesion, and the risk stratification, which is to say, how likely do we think it is that this patient would have a malignant lesion. And management strategy, in addition, I think it's important to keep in mind that patient preference and physician preference should be considered as well when making those management decisions. And I thank you very much for your attention.